Welcome to a GSA Momentum discussion on the interrelationships between nutrition and oral health in older adults. Topics selected for this series are experiencing momentum in the field of gerontology. I'm Roseanne DiMaria-Ghalili from the College of Nursing and Health Professions in Philadelphia and will be serving as your moderator. Joining me are our panelists, Dr. Judy Haber from New York University's Rory Meyers College of Nursing, Dr. Michele Saunders from the University of Texas Health Sciences Center at San Antonio, and Dr. Katie Starr from Duke University College of Medicine in Durham, North Carolina. Please note the handout for today's session includes panelist biographies and suggested key references. Let me orient everyone to the flow of today's program. During this 60-minute session, I'll be posing questions to our panelists. At the end of the Q&A session, we'll have an open discussion and invite participants to submit questions. Finally, I'd like to thank our sponsor, GlaxoSmithKline Consumer Healthcare, for their support of today's event. So now let's get started. The first series of questions we'll focus on is about why should we care about nutrition and oral health risks in older adults? Poor nutrition is related to adverse health outcomes in older adults, including morbidity, for example, falls, impaired wound healing, mortality, and increased healthcare costs. Decreased food intake or changes in dietary patterns are known risk factors for poor nutrition in older adults. Impairments to the oral cavity can impact food intake. In essence, the importance of nutritious food and good oral health and healthy aging are intertwined. Let's turn to our panelists to take a deeper look into the age-related changes that contribute to nutritional and oral health risk. So we'll start now with Dr. Starr. Can you help us understand the physiological and metabolic changes with aging that place older adults at nutritional risk?
Absolutely. And thank you, Roseanne, for that wonderful question. So it is really important to understand that there are inherent changes with aging that impact nutritional risk. And those changes include physiological, metabolic, and environmental changes that we know occur with aging. So specifically thinking about the physiological changes, as we get older, we know that our activity starts to decline. In addition, we also see a reduction in our resting metabolic rate and basal metabolic rate. So our energy needs also decline. In addition to that, we see this reduction in lean muscle mass and increase in fat mass and fat distribution. So we actually see more adiposity around the abdominal section, and we start to see that loss of lean muscle mass in our appendicular areas, so our arms and legs. The other components that occur with aging are the sensory functions. So we see a decline in the ability to taste, ability to smell, obviously a hearing and seeing as well. And then the innate changes that happen with our GI tract. So our ability to actually absorb nutrients begins to also be altered. So in addition to those physiological changes, we know that there are also metabolic changes that occur, and those include fluid and electrolyte dysregulation. We see a reduction in skin synthesis and hepatic changes that, again, are going to impact not only what we eat, how our body responds to food intake, but also how our body responds to medications as well. And that goes along with our reduction of renal clearance. And then we have the anabolic resistance of protein and reduction in ability to stimulate muscle protein synthesis with age. And so we also see some of those other changes that all kind of tie back to those physiological components, such as that loss of lean muscle mass. And I also just want to emphasize the fact that we do know as we get older, we also have chronic health conditions, an increase in chronic health conditions and the number and prevalence of chronic health conditions. And all of that is going to elevate these physiological and metabolic changes where we will see even more impact on the components of change with age. So it is really important to note that not only with age do we see these inherent changes, but also with the number of chronic health conditions. And then also when we start to look at aging and fixed incomes, we will also note the food insecurity components that go along with those environmental changes that ultimately put older adults at greater nutritional risk.
Well, thank you for that detailed analysis. And I'd like to turn now to you, Dr. Haber. What are some of the age-related changes associated with poor oral health?
Well, you know, poor oral health is linked to numerous age-related conditions that people come to their senior years with that increase the risk for poor oral health and poor nutrition, which, of course, in the nutrition area can progress to malnutrition. The vital connection is really infection and inflammation. Both increase the risk for oral infections related to tooth decay, gum disease, including gingivitis and periodontitis. Over 80% of older adults is 65 and older, have periodontal disease. And there are other infections, abscesses, and we have tooth loss, ill-fitting dentures, which contribute to painful chewing, poor food choices, and the like. And Katie, your physiological and metabolic description was great. When you think of the number of chronic health conditions ranging from stroke, cardiovascular disease, diabetes, cancer, respiratory disease, all the arthritis and movement disorders like Parkinson's, dementia, and then there are the behavioral health issues, depression, anxiety, substance use disorders, and the like, that all contribute to nutritional problems, whether it's being able to hold a fork, open a jar, swallow food, have any desire for food. There's a vast array of oral health implications that are intimately linked to nutrition, good nutrition, bad nutrition, and overall health.
Thank you for that detailed discussion, Dr. Haber. I'd like to turn to you now, Dr. Saunders. We heard a lot about age-related changes that contribute to nutrition and oral health risks. Can you maybe elaborate a little bit more on oral health, and especially in older adults?
Sure. Basically, I'll start with the fact that our health culture minimizes oral health. We look at it as only a tooth instead of an integral part of the human body. And that means that in order to progress with improving oral health in our country, we need all of us, from patients to clinicians, everyone, policymakers, improved oral health literacy. We have a lot to learn. There have been 4, in fact, Institute of Medicine, National Academies now, reports which lay out in detail ways in which we can integrate oral health into overall health care. And if anyone wants a list of those, I can provide them. Untreated oral disease leads to more systemic health problems, while management and treatment of chronic comorbid diseases are extremely expensive. There's growing body of evidence supporting an association between oral health and systemic health, as Judy pointed out, and so did Katie. For example, increasing research is ongoing on the role of chronic inflammation, whether it's from periodontitis or other things, on diabetes, cardiovascular, cerebrovascular disease, and pulmonary disease. And oral inflammation plays a big role. Early research did some biopsies of cusps and cardiac valves, and they found oral bacteria growing on those cusps. So there is clearly an association, and the research is increasing in time. We also know that salivary hypofunction, whether it's due to medications, diabetes, autoimmune disease, and other diseases, not only affects taste, but affects the integrity of teeth. Saliva increases tooth integrity through buffering, antibacterial, antiviral, and antifungal activity, and contains calcium and phosphate ions for remineralization of teeth.
Well, thank you. That's a lot to unpack. But I'd like to move now into our next topic, social determinants of health. I think you've all touched on this a little bit. And we know that social determinants of health greatly impact nutrition and oral health as well. These include economic stability, neighborhood and physical environment, education, food, community and social context, transportation, healthcare systems that are accessible, affordable, and available. And now that we're in COVID-19 crisis, the COVID-19 has really exacerbated a lot of these challenges for many older adults, given that they're high risk and the need to maintain physical distance from others. In April, the National Council on Aging conducted a survey of their partnership organizations right early in the pandemic, and they found that there was an increased demand for home delivered meals during the pandemic among their stakeholders. So access to healthy and nutritious food is even more important now during the pandemic. And Katie, I'd like to ask you, could you elaborate a little bit more on food insecurity and some of the challenges that you've experienced with home delivered meal programs in terms of food options for older adults with impaired oral health?
Absolutely. Thank you. And just to elaborate a little bit more, the social and the environmental factors do play a very large role in our nutritional risk and are oftentimes underdiagnosed or underseen in our healthcare system. And it's one of the things that I think we could all do a better job at as we think about our aging patients or the individuals that we are working with. The other component here, and I think has been elevated by COVID-19, is the social isolation as well, and that decreased desire to have those connections where we used to see more connections, especially through our programs like the Older Americans Nutrition Act and congregate meals. So really kind of thinking about the impact that food insecurity has on our older adults is extremely important. So we do know that many of our older adults are on a fixed income and consequently they experience food insecurity. And the concept of food insecurity, as you already mentioned, Roseanne, is influenced by factors such as proximity to a patient's home, to a grocery store, and fresh food markets. And we know, thinking again about the COVID era, many older adults are scared to go out. And I think we have seen some movement in home delivered foods, but kind of understanding that even some of our programs like Meals on Wheels were halted there for a period of time because of COVID. And I think everybody revamped and figured out a way to make this happen. But I do want to emphasize the fact that, COVID-19 has definitely put a big component on our Older Americans Act nutrition programs, like our congregate meals. And again, thinking about too, that these financial constraints and also that difficulty of even being able to prepare food all fall underneath that description of food insecurity. So it's not necessarily not having enough money to buy food, but it's also not being able to cook and prepare foods. So again, I just want to emphasize that those components play a role. So when we think about our patient who's come out of surgery, who may not have the energy or capacity to be able to stand and cook, that person is still considered food insecure, even if they have the means to be able to purchase food. So all of those things are really important to think about. Now, particularly thinking about our wonderful programs, such as the Older Americans Act Nutrition Program. We have these programs that provide meals to our older adults. However, there's a lot of variability between the meals that are being provided. And we don't always think about our older adults' ability to chew, our older adults having dentured, missing teeth, difficulty with chewing. And we all know that there are many older adults, at least the patients that I've seen, they're like, I can gum anything. Well, not everybody can do that. And it's important to note that when we provide food, and if we're going to provide these foods, we have to start thinking about, are these individuals actually going to be able to consume these nutrients? Because it's fine if we say that these are the foods that we're giving them and these are the nutrients that we're providing and this is the amount of calories. But if they're not able to consume those meals, what really are we doing? So there is still a lot of work that needs to be done. There has been a lot of work that has been done. And I do want to make sure I emphasize these programs are phenomenal. They really are. They're life-changing. And we know that many of our older adults are actually, not even utilizing all the financial help that they could be getting. For example, our SNAP program, many of our older adults actually meet the USDA Supplemental Nutrition Assistance Program requirements, but actually many of them don't participate. And I think it is important for, especially at this time, with COVID being here, that we remind our older adults that they have access to some other components that could help them make sure that they're getting the nutrition that they need, but also being able to add some choices in there that they may actually want to have and be able to consume those foods. So really, really kind of emphasizing not only on the prevalence of food insecurity, but also the importance that if we're going to be providing services, we have to really think about what are we serving, what are we giving, can it actually be consumed?
Yeah, that's great. And just a follow-up point, I'm not aware of any home delivered meals programs that actually have an oral health intake assessment, right? So that they could tailor the meals appropriately. Do you know of any, or do any of the panelists?
So we, many of the Older Americans Act nutrition programs implement the Determined checklist, which do ask about, do you have any problems with chewing? Do you have any problems with your teeth? But what's done with that information afterwards is still a question. We're collecting the data, but nothing is really happening, I think, systematically. Small places, we know that there are definitely things that are happening, but I think in a large systematic component or nationwide, we're not seeing it on the level that it really needs to be at.
Great. Well, thank you. Judy, would you be able to elaborate a little bit more on some of the community and social aspects of nutrition and oral health, especially from maybe an urban perspective?
I would. I'd be happy to. And I think an important point that is often forgotten is the influence of behavioral health or mental health on both nutrition and on oral health. So if you think about the number of adults, older adults, who experience bereavement, loss, real acute or extended grief, those who have alcohol, substance use disorders, who are literally depressed, clinically depressed, or who are just lonely. Over 46% of women live alone, just as one. We know that the highest suicide rate among older adults is single men who've lost a spouse and are living alone. So that's just an estimate, a little small example of the estimate of the impact of loneliness, isolation, that can quickly become depression. So if you think of the symptoms of depression and whether they're anorexia, apathy, loss of energy, inertia, if you really want to be clinical, it would have an impact on shopping for food, preparing meals, and the prospect of eating alone. It can be a pretty grim thought to sit at a kitchen or dinette or dining room table or on a snack table in front of a TV and eat alone meal after meal. And the thought of shopping and preparing meals, it just becomes overwhelming. And it's not interesting because you're only doing it for yourself. And then there's the aspect of older adults who have poor dentition. They have tooth loss, they have cracked teeth, broken teeth, and the negative effect it has on their self-image and their self-esteem, and which will influence the degree to which they self-isolate. And when you think of the low energy associated with depression and loneliness, it also decreases the motivation to engage in self-care behaviors like brushing your teeth and oral hygiene. It becomes a vicious cycle because then there's an risk for oral health problems like decay, which in turn can result in infection, painful chewing, tooth loss, high carb, easy to grab diets that have all kinds of ramifications in and of themselves. It's really a vicious cycle. And then if you add COVID into the equation, COVID-19, this has only exacerbated these community-based programs and problems, actually, because of the very appropriate urging to mask, stay at home, not go to indoor and crowded places like supermarkets, can't go to get your health promotion checkups with the dentist, cleaning, dental hygienist. And so it just adds more momentum to that vicious cycle. And let me add one more thing related to COVID-19, and that is the isolation of older adults from usual social supports. And whether it's family, whether it's the senior center, whether it's Meals on Wheels, as you mentioned, Katie or Roseanne, with them being halted for a while, these are community resources, including churches and synagogues that have senior programs, congregate meals that people rely on for socialization and nutrition, which are all denied to our older adult population right now, and just give heightened motivation to isolating oneself and becoming depressed and lonely, with the related neglect of nutrition and preventive oral health care. So we really have a mess on our hands in terms of trying to ensure the oral health and nutrition health and the overall health of older adults who have usually multiple chronic conditions as well.
Yes, I couldn't agree more. And also, when you think about the isolation, especially in terms of transportation, if individuals can't get out and ride the bus or get on a train to go to the supermarket, or if they live in rural areas and they can't drive any longer, it becomes more isolated and more at risk for food security or food insecurity.
Right. And how many older adults under normal circumstances who have the mobility to get out, at least in their neighborhood, you think of affordability in addition to mobility, they go hunting and pecking around in different supermarkets using their food coupons, day discounts, and the like, day-old food to assemble a more nutritious, affordable set of meals for themselves. I've been in some homes, apartments, and houses with students in community health nursing courses where the only food in the fridge are the remnants of AB4's Meals on Wheels delivery, and there is literally nothing else in the fridge. Scary. Can be very scary.
Well, thank you. There's so much work that we need to do as leaders in the field. And Dr. Saunders, I want to turn to you. Really, we haven't addressed yet this accessibility, affordability, and availability as it pertains to overall oral health for older adults. Can you shed some light on this for us?
Sure. We know from the Centers for Disease Control that 20% of older Americans have untreated dental caries. And we also know that tooth loss is associated with increased mortality. One of the things we haven't addressed yet is the issue of disparities. We find that Blacks, Hispanics, and those with lower income or less education have higher rates of dental disease, oral cancer, and periodontal disease, and are more likely, if they're still working, to have job difficulties. And as Judy pointed out, these older adults in minority and lower income brackets can also have lower self-esteem. An older adult not living in poverty will have 5 more teeth than those in poverty. Minority and poor older adults face barriers in access to oral health care, resulting in disparities, low dental utilization rates, and financial difficulties. Only 40% of older adults see a dentist annually. That's only an increase of 2% since the year 2000. The loss of dental insurance after retirement plays an immense role. Some people are quite surprised once they retire that they've lost their dental insurance. Not everyone can afford the AARP dental insurance plan through Delta Dental, and Medicare currently covers little to no dental coverage. Meanwhile, we have not had a big enough increase in geriatrics dental education in dental and dental hygiene schools. Medical and nursing schools have even less geriatrics oral health education. We're at a crossroads of medicine, dentistry, health policy, and healthcare delivery. This is a great opportunity to improve older adults' oral and overall health.
Thank you. And I think that you lead us at a good point where we could shift into looking at interprofessional relationships. We know that most older adults with complex care needs require a diverse interprofessional team of healthcare providers to manage and coordinate patient-centered care. All members of this team should make sure patients are screened for dental problems and poor nutrition across healthcare settings. But we still are siloed, right? Dentists and hygienists usually care for the mouth. Dietitians focus on the diet, but all team members really have a role to play in these areas. So I'm going to present you all with some scenarios. And Katie, I think older adults that need surgery are probably some of the more complex care problems that we see because they have multiple chronic conditions in addition to the stress of surgery. And it's across, you go from the home to the hospital, back to the home again. So can you talk about some of those interprofessional relationships that are really important to provide good nutrition and oral health care in older adults who require surgery?
Yeah, absolutely. And I will say that I have the privilege of working with an interprofessional team at the Durham VA, and we work in a perioperative clinic, and it has truly opened my eyes to the needs of working as an interprofessional team. I mean, we talk about it. I know we talk about we got to get away from the silos, but it wasn't until I actually got integrated into that environment that I realized the value of having, our geriatrician, our surgeon, our anesthesiologist, our chaplain, our OT, our PT, our social worker. But you can see I did not say dentist or dental hygienist in that component. And that is one of the areas that we truly are missing, the dental and the dental hygienist component. One of the things that we do remind our patients about, particularly as they're preparing for surgery, is, making sure that they bring their dentures, making sure that they have them with them so that they can eat when they're there. And, same thing with their hearing aids. But that's really not enough in regards to being able to deal with the larger issue at hand that Dr. Saunders clearly pointed out is the fact that many of our older patients are going into surgery with poor dentition, and then that catabolic load that surgery causes, in addition to what other metabolic changes are happening, elevates those calorie needs to a level that is almost impossible to achieve, especially in the hospital setting. And then if we add that level of oral health challenges with our oral health, you can see how it's a double whammy. We're never going to get ahead here. And I know that we oftentimes have to fight for our patients when they do have poor dentition and really kind of have to say, okay, well, this has to be fixed before we can actually potentially move forward with surgery. It's one of the things that I think we're slowly moving towards, especially in the perioperative realm, of optimizing our patients before they go into surgery. And I have to say that we really have to think about every component of the body. I think working in gerontology, working in geriatrics, we really try to view the older patient as a whole, not as just a part to a sum, and if we're going to do that, the next layer here is moving on to our oral health. It truly is. It's been an honor to work in this team, and I really do hope, and as the thing we've all shared, it seems like there's this movement, and we're starting to get there. We're slowly inching our way there, and I really hope that this helps with the momentum of really emphasizing the fact that the interprofessional team, we all play a role. We're all important. How do we incorporate not only understanding the role of dentists and dental hygienists into our care of our older patients, but how do we start pulling them in, and how do we help our patients afford this care? It's just it's heartbreaking. It really is, when we start thinking about our patients and their ability. It's impacting their ability to get the nutrients that they need for them to actually thrive and have the quality of life that we hope for. So again, I think that interprofessional team is essential in this, but we have to have all the players at the table for this to actually work. And I hope that this kind of helps bring that to light even more.
Thanks, Katie. And Judy, I know you've done a lot of work with interprofessional teams in this area. So what has your experience been working with teams to address nutrition and oral health needs for older adults, and including those with chronic conditions like cancer, heart failure, etc.?
Well, I think that oral health and nutrition provide amazing clinical exemplars for promoting development of interprofessional competencies across the professions that students should be exposed to from day one of their pre-licensure or post-licensure curriculum. Every profession has a contribution to make to promoting both oral health, nutritional health, and overall health. And if you think of the chronic conditions becoming the grist for the mill, the clinical exemplars that we use to bring teams of students together across the disciplines, and it can vary, it's a potpourri, and you bring different team members together for different kinds of experiences, from pregnancy through palliative care. It's been amazing. It's not easy, because just logistical things like different schedules, different curricula formats, resources needed. I mean, it's not expensive, but it's also not inexpensive to run these programs. But for example, at NYU, we had teams of dental students, undergraduate nursing students, and nurse practitioner students who all have older geriatrics, gerontology integrated into their curriculum. They went to 14 senior centers in the Bronx, largely Hispanic population, and they teamed to provide both overall oral health literacy presentations, oral health and diabetes, and oral health and nutrition. So the seniors, the older adults, then said to the staff, well, now that we have all this great information, where are we going to get this oral care? And so the staff at the senior centers did a scavenger hunt in the Bronx, in their catchment area, and they came up with a list of affordable dental resources because, Michele, you are correct. 64% of older adults have no dental benefit. And the most significant reason for not seeking oral health care is they can't afford it. The cost is really the major factor, according to the ADA. So we have created a number of live, in-person, simulated, telehealth, telemedicine experiences for students, web-based curricula, toolkits that students across the professions can use. And I do want to give a shout out for Smiles for Life, the National Interprofessional Oral Health Curriculum that has 11 modules now. It's just coming out in its newest 4th edition that prepares everybody from community health workers, nurses, pharmacists, dietitians, physicians, et cetera, to integrate oral health into the overall health they provide in both community-based and acute care settings. So I highly recommend it. And there are other programs that exist. I lead the Oral Health Nursing Education and Practice Program, or ONEP. We have a rich website that is a knowledge hub, both for nursing, but really resources that can be used across the professions. And there is a growing number of champions across the country that are embracing this interprofessional model. We believe that students, the future generation who are being prepared to practice team-based whole person care, need to be exposed over and over again throughout their curriculum to these interprofessional experiences, so that for them, there is brain memory, clinical memory, just like we have muscle memory, so that when they graduate, they can hit the ground running. And I will say that residents, the last stop on that learning chain, regardless of which profession, need to be held accountable for these interprofessional competencies as well, related to oral health and nutrition, as they belong and link with overall health, especially for older adults. And I think programs like the ACE units, that were the original ones, and the PACE programs are good examples of clinical programs that are operational that do attempt to use this interprofessional approach. It's essential, especially for older adults.
Absolutely, I couldn't agree more. And I'm waiting to tap into Michele about the role of the interprofessional team on providing excellent care for frail older adults, especially those in skilled care facilities or rehab settings that may have stroke, Alzheimer's disease, dementia. They have so many challenges. And in your experience, what have been some of the programs that you've been involved with that have impacted positive outcomes?
Well, I don't want to lose the term interdisciplinary, because interdisciplinary came before interprofessional, and it was developed actually in the early 1980s by Doctors Larry Rubenstein, Itamar Abras, and Bob Kane at the Sepulveda VA in California. They did interdisciplinary team care and geriatric evaluation and management units for frail elders and in their nursing home care units. The VA has led the way in geriatric care since anybody ever thought of it. And one of the key findings of all the research that they did and that came out in every one of their editions of their textbooks is that this interdisciplinary and interprofessional team care results in better health outcomes with things like a reduction in rehospitalizations, shorter stays when people are in hospitals, and the outcomes have really proven to be significant. Crossover of team roles is a key feature of any quality team. Everyone needs to learn how to do oral health screening. Dr. Connie Mobley, dietitian, PhD nutritionist, and I have led statewide training for nutritionists on how to do oral health screenings. We had them screen one another to learn how to do it. And in a team, a proper interdisciplinary team, you cross over roles. You have dental people picking up on depression and referring to the psychologist on the team, and vice versa. And because of these findings early on, minimum data set assessment tool came about. And that's certainly required in the first 20 days of admission to a nursing facility if that nursing facility receives Medicare or Medicaid funds. And it does include a minimum dental assessment, though that's been decreasing in the amount covered over the years, such as swollen or red gums, broken teeth, problems eating because of the dental condition. And these things have really made a difference in getting folks the care they need. Now, if we can just get them more than emergency care, we'll be headed somewhere.
Well, I couldn't agree more. And at this point, I would like to ask the panelists, do you have any other thoughts before we move into the question and answer session? Anything else you'd like to add at this point?
Could I add,
Are we
Michele?
not going to cover, are we not going to cover the Medicare, Medicaid legislation issue?
So, and before we wrap up and go into the question and answer, can we just have a temperature reading about what's going on with Medicare and Medicaid policy and how that impacts oral health coverage?
Can I address that?
Please go right ahead.
Okay. Well, we certainly know that oral health has been routinely excluded in prior public policy initiatives that were begun to improve access and quality of healthcare in the U.S. And from Medicare, Medicaid through to the Affordable Care Act, discussions consistently left out oral health. And we've talked about the fact that there's not adequate oral health insurance for folks. Well, we do have some coverage by Medicare, but it's for severe illnesses such as organ transplants, head and neck radiation, heart valve transplants, and other serious life-threatening conditions. Preventive care extractions will happen. Well, there's been a lot more recent legislation that has come up over time. They've been defeated because they've been seen as too expensive. However, there has been recent research by insurance companies and others that have shown actual cost savings when preventive care is provided for those elders with cardiovascular, cerebrovascular diseases, diabetes, and other conditions because of the avoidance of sequelae from oral neglect. And that is the place to convince our legislators and public policy, other folks, that's where we need to head. If we can help them understand that prevention prevents further disease and is less expensive than treating that further disease, we're on the way.
Well, thank you. And Judy, would you just like to maybe give a pitch about the work the Santa Fe group is doing, which ties into this?
Yes. Well, the Santa Fe group, which is an oral health policy and advocacy think tank, is one of the leaders of a national coalition signed on to by 135 national organizations to support advocacy for a medically necessary oral health or dental Medicare benefit. As Michele was saying, an ounce of prevention is very cost effective, and there are many studies that have demonstrated this. And the interesting thing about the medically necessary benefit is that it is within the purview of CMS to authorize the benefit for the medically necessary care of specified health conditions like organ transplants or head and neck cancer and the like, and does not require legislation that could be shot down, if you will, in a summarily kind of way. So we are looking forward to moving forward on this initiative. The signposts are quite encouraging, and we are in our coalition, that is in deep conversation with the leaders at CMS to work on making this happen. So we are very optimistic about this as part of a brighter future, and then we will open that door even wider for a broader Medicare dental benefit.
Well, thank you, everyone. I think this has been a great discussion thus far on the interrelationship between oral health and nutrition from some great leaders in the field. And we should be proud of all the work we've done so far. We have a lot more work to do, but knowing that we have great leaders and working as a team together, we could really move the needle on all of this and improve care for older adults. So I'd like to stop now and take some questions from the audience and thank the panelists for their attention thus far. Well, welcome everyone to our live question and answer session. And before we get started, as we wait for questions coming from the audience, I'm going to open up with our panelists a question. There's been a lot of work actually on interprofessional, the role of nutrition in interdisciplinary and interprofessional education. The National Heart, Lung, and Blood Institute held 2 workshops on this topic in 2012 and 2017, and I was lucky to be part of that panel, and there has been a lot of papers published in this area. But, really, let's stop for a moment and focus a little bit about the team approach in terms of oral health. So how should primary care providers, physicians, nurse practitioners, nurses, PAs, dietitians, and other team members integrate oral health into their care with older adults, especially those that have one or more chronic conditions? So as we're waiting for other questions to come in, I may just tap into each one of everyone on the panel to address these issues. So maybe Judy, we'll start with you first from the perspective of nursing and nurse practitioners.
Thanks, Roseanne. Relevant for nurse practitioners, nurses, but also for physicians and physician assistants who are, and any other member of the primary care or acute care team for that matter. Basically, our position is that oral health should be a required component of overall health and any kind of health care that is provided. So we recommend using and integrating oral health, starting with asking about it when collecting the health history, looking in the mouth and actually doing an intraoral exam, not just sticking out the tongue, asking patients to say ah and looking right past the mouth. So we advocate using the he-not approach so you cannot forget about oral health. And then deciding which strategy or strategies are going to be used to integrate oral health into the overall management plan, and then to provide that care, which may include health promotion, behavioral lifestyle changes, pharmacological management, but of course, referral to the dentist and making sure that every patient has a dental home for sure. And then the important piece is, and we say in nursing, if it's not documented, it didn't happen. So making sure that there is a required field for oral health documentation in the electronic health record. And of course, if we had interoperable electronic health records across nursing, nutrition, dentistry, social work, etc., that would be the best. But that is what we advocate in terms of always thinking about oral health when you're thinking about overall health.
Well, thank you, Judy. Katie, maybe you could chime in a little bit and focus on about the role of the dietitian in oral health.
Yeah, absolutely. I mean, I think Judy did a beautiful job explaining the importance of, our role of making sure that it is at the forefront. And again, I think many times we forget, we don't always have the time necessarily. We're focused on one problem or one issue, and sometimes that oral health will kind of go out the window. For the dietitian, one of the big things, we talk about is, making sure that they can get in and making sure our older adults are getting the adequate nutrition that they need for them to thrive. And if we're not looking in the mouth, if we're not talking about oral health, if we're not asking about their ability to chew, the health of their teeth, how often they're going to the dentist, do they have a dentist? Do they have access to a dentist? Do they need a referral? Do they need some resources? All of those things should be things that we are automatically asking our patients so that we have a better understanding of their ability to actually chew and swallow and get the nutrients that they need. One of the things that we've done in our clinics is actually pull together resources so that we can actually give our patients a list of low cost or even free dental care around the Durham, Raleigh area. So, even being able to create some resources for folks so that they're not having to do all that guesswork too. That's another thing, is that it's really hard to figure out, and there's always a long waiting list. And if there's a way we might be able to, help remove one of those blocks, one of those barriers to getting care, I think that should be a priority on our list.
Great, thank you. And Michele, maybe you could expand upon this a little bit more. And I know when we had our interview, as we were preparing for this, you shared some really great stories about the role dentists play in oral health care in the nursing home setting or in skilled care facilities, and different types of appliances, which, you know, all my years as a nurse, I've never seen some of those appliances. So can you talk a little bit more about really how we can really work with dentists to promote oral health in individuals that maybe have strokes, and especially those kind of conditions?
Well, actually, Katie put her finger on it during our earlier discussion when she said that there's no dentist on most of the healthcare teams. Dentistry is primary care, but most health professionals have forgotten that. They think of primary care as medicine, nursing, and social work, and it sort of stops there. And that's not it at all. And I think what we need to do is automatically integrate dentistry into all of our primary care teams. And that will help a lot. In terms of nursing home, they have, by law, since over 87, been required to have an interdisciplinary healthcare team treating all of the patients and doing interdisciplinary care planning for that treatment. And the real thing that I like so much about interdisciplinary teams is not just that it includes everybody, but it also includes the patient. It includes the patient's family, if it's appropriate, and leadership of the team, which is why it's called interdisciplinary and not just interprofessional, rotates depending on the need that's being addressed at that team meeting on that patient every week. So it may very well be that the dentist and the hygienist, if the hygienist is participating as well, point out the fact when they're discussing the stroke issues patient that the patient needs an adapted tool that you and I had talked about, to be able to hold a toothbrush. Maybe they can't afford an electric toothbrush, which is a nice thicker stem to hold on to for arthritic hands than usual. And so they don't know about what can be done, and the hygienist and the occupational therapist, if there is one, can work on that together. So there's a lot to be said of the kind of collaboration that can occur. And a lot of dentists don't have the training to know that if you have a patient with a stroke, you can actually work with a speech language pathologist and a physical therapist to repattern the bite. So you can actually make a denture if needed, or another type of prosthesis. And the research that I've done with speech language pathology people, we actually made prostheses for speaking for some of our stroke patients, and then they take that out and put it in their pocket and pop in the one for eating, since your tongue goes in different places for speaking than it does in eating. And those are the kinds of training issues that can happen across disciplines as well, so people know what resources they need to access to improve the care, and we can all work together to do that.
Well, that's exciting. We talked a little bit about reimbursement. We touched on that, and we know that there's issues around reimbursement for dental and oral health, but I think we handled that. I may come back to both Judy and Michele to see if they have any final thoughts on that, but I really want to turn it over to Katie, because a question that always comes in all the time is, does my insurance cover a dietitian? You see dietitians in the hospital, you see them in facilities, but that transition period in the home setting, and you want to work with a dietitian, how do I go about finding one? Does my insurance cover it?
Absolutely. And thank you for that question, Roseanne. It is, another mystery of the insurance company and debacles that we have. So accessing a registered dietitian outside of the hospital care setting, it really can be very challenging. But it doesn't have to be, and I'm going to get there. It can be challenging if you're trying to do it on your own. I do want to just say really quickly, though, that Medicare covers medical nutrition therapy counseling with a registered dietitian in adults 65 and older, with those individuals who have diabetes and kidney disease. And they will follow someone. They also provide care for older adults who've had a kidney transplant for 3 years after that transplant. However, it's very interesting because it's estimated that approximately less than 1% of Medicare beneficiaries who are actually eligible for medical nutrition therapy counseling utilize these services. So they
Wow.
are definitely underutilized, like many of our services are. In order to actually start utilizing these services, a physician is going to have to refer the patient to a registered dietitian nutritionist. So I think one of the contributing factors of the lack of utilization could be that not enough physicians even know about the Medicare benefit for medical nutrition therapy, or they don't know how to refer to an outside dietitian. And both of those things, again, as I was saying previously, with our older adults, especially those who have multiple chronic health conditions, everybody has just a limited amount of time to be working with patients. And so sometimes it's easier just to prescribe a medication that you can get versus having to try to figure out how to refer to a dietitian. And so I think one of the things is that we have to not only educate our healthcare providers and professionals about the services that registered dietitians can provide and the fact that it's actually covered, but we really also need to be educating and educating our patients that these services are available and having them advocate for themselves and asking their physician for a referral, because when they do that, they're more likely to actually get that referral. And how do we go about finding a registered dietitian? Well, that is very easy. All you have to do is go to eatright.org, and there is a red button in the top corner of the website. You click on that and it says find an expert, and then you just type in your zip code, and it provides a list of dietitians in your area that take Medicare. And so that's just it's very quick and very easy. But if you don't know that resource, it may take a little bit more time and work to find it. So I do want to promote those registered dietitians out there and make sure that we are educating not only our patients, but also our physicians that these services are available. But we need their help to get our patients to these services.
Well, that's great. A lot of helpful tips that I didn't even know about. So I'm sure everybody else appreciates that as well. We have a few more minutes left. Any closing thoughts, Michele, Judy, or Katie? I'll start with you first, Michele.
I always like to take off from a speaker who said something really significant, and I wrote down eatright.org, knowing that I have a PhD clinical nutritionist as one of my very dear friends, and I never knew about eatright.org. I'm embarrassed. But I do think one of the things that we can do to help one another out truly is within our settings, whether it's email, continuing education, 30-second blurbs, or whether it's a newsletter. I, for example, really teach dental hygiene folks that they need to actually take over nutrition in the dental office and do the screenings and use the determined checklist, and actually always have a column in the practice newsletter about nutrition. And if they should find one to make friends with, so that they can be accurate. And I really do think that teamwork is the end all be all do all of making all this come together and happen. And it's why I'm so grateful to GSA for doing this momentum discussion and for making this happen and taking steps, and to thank GlaxoSmithKline for their sponsorship of this, because it was so desperately needed, and it's good to see progress being made.
Great, thank you. And Judy, do you have any closing comments?
I do. First of all, I recommend the What's Hot newsletter about malnutrition, oral health, and older adults to everybody. It is a wonderful publication, and I know it's available on the GSA website. I also think that sessions like this are a paradigm example for how we can break down silos and overcome the separation between our professions. If everybody would just think about a diabetic patient and how that diabetic patient would benefit from the team-based care to be provided by primary care providers, dental providers, and nutrition providers. It would be a much more beautiful world and a healthier world for that large patient population, just as one exemplar. And I really thank GSA for bringing our attention and giving us the time to show how silos can be broken down by all of us.
Well, thank you again, everyone. And just a quick wrap up and thank you to our sponsor, GlaxoSmithKline Consumer Healthcare. And please visit the What's Hot section of the Gerontological Society of America for our new publication on the interrelationship between nutrition and oral health. And there are some other What's Hot hubs out there on oral health and as well as malnutrition in older adults. So we're really excited. And again, thank you, GSA, and thank you, Glaxo, for all your support. And to my wonderful colleagues, it's been a pleasure working with all of you.
Thank you.
Really great.
Great. Thank you.